So today's discussion is about femoral puncture. It's one of the easiest and simplest things to do, but it can be the most worrisome thing for an interventionalist. Unless you have a very safe and a secure and a very safe femoral puncture and a closure, many times even after very successful and very difficult procedure, the doctor can land up in serious trouble. So today we have Dr. Anil Karapurkar telling us, sharing us the tips and tricks of how to do a very safe and successful femoral puncture 100% of the time. So unless we have 100% of the time a safe puncture, the procedure is not going to happen. So sir, shall we start with the talk? Over to you, sir. So you want to say some introduction? You can start.
Thank you, Gigi. And I always like to start by saying that whenever you're doing a neurointervention or any surgical procedure for that matter, there is no such thing as routine. Don't treat it as routine. You should be very careful with every single procedure and plan every single procedure. So when we are doing a femoral puncture, we should find out what we are doing it for. Just don't be a mechanical person to come and do a femoral puncture and do the angiogram. Find out what it is for, because the investigation will be tailored accordingly. So we always obtain an informed consent, explain the procedure to the patient. Many times the patient is very anxious, especially when it's a neuro procedure. They are very anxious. So we sometimes may need to give diazepam. If again atropine, usually we don't give for this patient, but you may need to give it. NBM for 4 hours for adults, 6 hours for children. And very important, before touching the patient, before puncturing, always feel both femorals, both popliteals, both dorsalis pedis, both posterior tibials. Because after you finish, you realize suddenly there is no pulse below. So that is dangerous. So before you begin, always palpate both femorals, both popliteals, both posterior tibials, both dorsalis pedis. There are some blood tests which are required. Creatinine is very important because contrast gets straight in the kidney. So even with large volumes of, even up to 2 or 3 milligrams of creatinine, you can still do an angiogram, but then you will need to use as little contrast as possible. So the important thing for these patients is to make sure that the patient is well hydrated. It might be a good idea to admit the patient the day before, give IV fluids, give normal saline as an infusion the day before, and in the morning start it in the morning. Acetylcysteine or mucomix is often given. Some believe it is of no use at all, but for whatever it is worth, all of us start it at least 3 days prior to the procedure, and we continue with it for 3 days post procedure. And if the creatinine is high and if the patient is acidotic, then we also give soda bicarb when we are starting. But try and restrict the volume of creatinine by the volume of contrast. And today on these good high flat panel machines, we can do a good angiogram with diluted contrast so that you use less volume of contrast. It is important, of course, to know the PTT, PT or BTCT, because usually the cutoff for INR is 1.5. Usually we try and avoid it. But if a patient comes, say for instance, patient is already in anticoagulation, comes with acute stroke, you cannot wait. So you have to go ahead and do it, but be very careful. So try and do a single wall puncture as far as possible. Electrolytes are always important because they can cause bradycardia, hypotension. So always check on electrolytes with these patients. Then if a patient is a stroke patient, it is better to give the patient, make sure the patient has taken aspirin and clopidogrel. And if the patient is on heparin for some reason, say for instance, cortical vein thrombosis or intracranial venous thrombosis, patient is on IV heparin. So we have to, half-life is 1 hour. So we stop it 2 hours before the procedure and take the patient out. Ideally, repeat the APDT before we take the patient out. What are the materials that we should have? Lignocaine, of course, 1%. Sensor cane, which is a long-acting anesthetic, is usually not used, but it can be used if you anticipate a long procedure like an intervention. We need puncture needles or angiocath. we need a sheath. The introducer sheath consists of a sheath, a cannula, which has a side arm. I'll show you the picture. The dilator, the wire, puncture needle. Some packets have a puncture needle, some don't. So you have a puncture needle separately. So you need a puncture needle. And what we have to remember is the pediatric sheath is 7.5 centimeters. The adult sheath is 11 centimeters. The wire for the pediatric patient is 0 to 1, and for the adult it is 0.35. So, and there is an 11 number blade to make a skin nick, especially if you are using a large sheath. For a 4 French sheath, you may not need to make a skin nick unless the skin is very thick. If it's a farmer who has got a very thick skin, it will cause a lot of injury, or the sheath will shear, will tear. So better to make a small nick with a 11 number stab knife. In neonates, in infants, in pediatric patients, in very fat patients, the femoral artery may not be palpable, in which case ultrasound guided puncture is safer. A lot of people in the West always do every puncture ultrasound guided, but we here, I think, generally tend to do puncture just by palpation. So, as I was saying, you have to always palpate on both sides, always prepare both sides, but you may puncture whichever side you are comfortable. Most of us who are right-handed are comfortable with the right side. But if the right femoral is not palpable or very poor, better to go from the left side. If you don't feel the femoral, then it might be better to do a CT angio to make sure that there is no stenosis upstairs and treat that first, or go through the radial or go through the brachial. We have had some patients where we first put a stent into the iliac and then we have gone through and done from below after the pulse has come back.
Sir, one question, sir.
What are,
Can I ask you something? So suppose if a patient has like one side is paralyzed in a stroke patient, isn't it better to puncture on the side which is weak so that now the limb movement is much less, flexion everything will be less, or do you prefer that? Or
no, because usually left side is difficult to puncture.
yes.
So right side is easy to puncture for us, but left side is usually difficult, not as all that easy to puncture. So we are more comfortable on the right side. We prefer the right side. But for a left-hander, I don't know, may prefer the left side.
Very obese patients, who have a huge stomach, especially ladies. So you put a
for very
strap
fat
in the abdomen.
patients, or for very tiny patients also, we keep a small pad under the buttock so that the hip gets raised. If there is a fold of fat, sometimes there is a fold of fat which is covering the puncture area, then we have to strap it up. So we pull a strap up all the way to the shoulder so that the whole fold of abdominal fat gets pulled up. And then, of course, ultrasound is, if it is absolutely not palpable, we go by the anatomical landmark and try and puncture. But you should also make sure that you have a needle which is long enough to reach the artery. Because if a very fat patient, luckily that has never happened to us so far. We had a 120 kg patient, but luckily we were able to puncture by using the anatomical landmarks. So what are the anatomical landmarks? So if you see the diagram that we have here, the midpoint, it is always the midpoint between the anterior superior iliac spine and the symphysis pubis. That is where the artery lies. But if you see the picture, yeah, that's right. So the nerve, the femoral nerve is on the lateral side. The vein is medial. The artery is in the middle. So if you see the drawing again, this is the head of the femur. So the artery is just at the head of the femur. That's it. So if you see that red, Gigi, if you can show on the red where it is blue and red.
Yes, yes.
Yeah, exactly. So it is at the femoral head. So some people like to keep an artery forceps as a landmark and then follow the needle follows that same path. So these are the needles. So next slide. So next slide shows the needles that we use. So there is the first one is a Seldinger needle. So that has flanges on the sides for additional support. So these were the original needles. Actually, these are not the original needles, but these came in later. Now here you have to count. If you use this, most of the times we counter puncture because there is a stellate inside, which is true for the next angiocath. The angiocath also you have to counter puncture, and in children, that is the technique. We always counter puncture. You will see blood coming into the inner cannula. Withdraw it, come back a little bit until you get a good pulsatile flow, and then advance it just as the anesthetists do. Advance it very slowly, rotating the hub so that it will go in. So as far as possible, the puncture should be in the middle of the artery. It should be a single wall puncture. And usually we infiltrate local along the track. So we will raise a wheel so that the patient doesn't squirm when we puncture, go with the big needle. And then we go along the same track into the artery and keep the needle on the artery. You can get the pulsation on the needle. And just a small jab and you enter the lumen. Don't keep on pushing. Most of the times that can happen. If a patient has had multiple punctures previously, like some cardiac patients, or the patient is very fat, you may not get the pulsation on the needle. The whole thing pulsates or you don't get pulsation at all. So in that case, we almost always counter puncture and then come back. But as far as possible, a single wall puncture. And the sheath itself, like I told you, consists of the wire. If we can go to the next slide. So the pediatric sheath I told you is shorter. The pediatric wire is usually straight. The adult wire has a J on it. So the J wire is very safe. Very unlikely that there will be any dissection or injury to the artery. So if there's any resistance at all when wire is being advanced, don't push. Adjust the lumen. Adjust because the bevel is long. The bevel may be partly in, partly out. So if it is adjusted a little by rotating the bevel, it may come back into the lumen and you may be able to advance the wire. So you have to be very gentle, not to use force. If you use force, you will cause a dissection. Any difficulty, best is to come out, stop the bleeding, wait for 5 or 10 minutes, then try again. Try a little above or a little below, usually above. The puncture site, of course, should be 2 centimeters below the inguinal ligament. The puncture in the artery is at least 5 mm above the skin puncture, so that it's like a valve mechanism, and also the needle will be at an angle. If your needle is vertical, it's difficult to keep the bevel in the lumen. It is always better to have the needle at an angle of 45 degrees. And in children, almost horizontal. The needle is almost perpendicular to the skin. In adults, you can keep it at about 45, but never vertical, except maybe in very fat patients where you have no choice. But as far as possible, 45 degrees. I had a video, but I think that video is not running, so we'll forget about the video. So we try and get a pulsatile flow. Sometimes you may not get a very good pulsatile flow. That is when you need to rotate the needle so that the bevel is nicely inside. And sometimes the blood may not be bright red as you expect from artery, because if the patient is hypoxic, the blood may not be as red, or severely anemic. It may not be red, it may be bluish. And sometimes it may be necessary to inject contrast to make sure that you are in the true lumen and not in the wall, not causing a dissection. But even if you do cause a dissection, you don't have to worry, because the direction of blood flow is opposite to the direction of our puncture. Blood flow is this way, we are puncturing this way. So when a flap is raised, it won't keep on growing because the blood flow is pressing it back out. Unless, of course, you just carry on and make sure that there is a big hematoma subintimal. A flap and dissection of the femoral artery is usually 99 times out of 100 not a problem, even if you do cause a dissection. But always
So one
remember,
question.
always be gentle. Go ahead.
So suppose if there is a dissection on one side, what do you usually do? You continue on the same side on a roadmap or go to the opposite
No,
side?
if there is a dissection, always go to the opposite side. It's not safe to continue on the same side because one may go through the same into the same intimal flap. So best is not to go to the same side, cross over, go to the other side and come from it. So if you've had a dissection on this side, you puncture the other side, you go into the iliac and do an angiogram and see what has happened to the side you have punctured. You make sure that there is no complication there, because if there is a complication, you will have to come down from the left to the right and tackle that. So if there is any trouble like that, always go to the other side, leave it and go to the other side. If there is a hematoma, it doesn't matter. If there is a small hematoma at the puncture side, you can still go ahead and do the same side. But dissection, no. Go to the other side. So, once you have got your wire nicely inside, the dilator walks in, because the dilator is tapered and the sheath is a snug fit on the dilator. So, usually the dilator and the sheath walk into the artery very smoothly. Sometimes if there is a lot of fibrosis, and that when you feel the artery, you will feel a lot of fibrosis, a lump there, or woody feel there. It is possible that the sheath may not go in. The dilator will go in, but the sheath may not go in. The sheath may tear, may shear. So in that case, sometimes what we have done is to, if you're sure you got a good nice puncture, the wire movement is smooth, then get the dilator only. You may have to use a little bit of force to go across all that fibrosis. So, or you may need to use a knife, especially for the superficial part, to make a track through the fibrosis. So once you got the dilator inside, then take the dilator out, put it back in the cannula, and then go back in with the dilator, with the sheath. So, but one has to be gentle. One should not use force. One should not cause injury to the artery. Roadmap, like I said, it can be useful. You can inject contrast, and especially if you are not sure what is happening, you can inject a small volume of contrast. But if you are wrong, if your artery, if your wire is not in the lumen, the patient will complain of pain. As soon as you go in, the patient will jump. So if there is any pain, it means that you are subintimal, you are not in the lumen with the wire. Sheath, when it goes in, may cause a little bit of pain, because now you are widening the hole the track that you have made. So I would not worry too much when the sheath is going in. But when the wire is going in, or when the dilator is going in, you have to be very careful. And make sure after you have got your sheath in, that there is a very good backflow. So always aspirate, get a good backflow. Sometimes there may be a bubble of air because the valves in the butt end of the sheath, there are two flaps. Some air can collect there. So always aspirate and then inject. And always inject with the syringe vertical, never with the syringe horizontal. Always hold the syringe vertical so that the air bubbles will come up. And after we have got the sheath nicely in, we inject heparin. So it depends on what the procedure is for. If it is for subarachnoid hemorrhage, sometimes we don't inject. Patient is very restless, had a bad aneurysm, we don't inject. But for most other patients, we give 1,000. If it is a patient with a stroke and bad arteries, we give more. We give 2,500. But most of the times, we give 1,000 for diagnostic angiogram. If you are using a new everything every time, you need not inject, especially if you are experienced. Like for many years, I did not use any heparin, because after I left KEM, everything was fresh. As long as we were in KEM, everything was reused. In fact, the sheath was cut until it would not reach the artery. So even the sheath was reused. But from the time I left KEM, I don't reuse anything. So the chance of anything happening, if you are not reusing, is very small. But if you are reusing, very important to use heparin and be very certain that your wire, everything is nicely cleaned and thoroughly cleaned of any debris inside the lumen or between the valves, even between the valves. So I know many of despite everything, many people reuse most of the thing, including the sheath. But we should not use, because sheath is relatively cheap, 650 rupees for a sheath or 700 rupees for a sheath. So I don't think it makes sense to reuse a sheath. So that's about the femoral puncture. And always I said, aspirate on the side arm. After we have finished, we are now taking it out. So many times we leave the sheath in, like for instance, we've done a carotid stenting, patient has had 5,000 units of heparin, you cannot neutralize the heparin. We leave the sheath in for 6 hours, repeat the ECT or APDT after 6 hours, and then pull the sheath out. So when we are pulling it out, ideal is to make an angiogram again, make sure that the puncture site is clean, there is no problem. And then aspirate on the side arm and then pull the sheath out. Always aspirate on the side arm. If the backflow is not very good, it means there is a clot sitting in the lumen. This clot can get dislodged and go distally. And I've had that happen to me long ago in the days that we were using. I had a clot which went into the toes and caused gangrene of the toes. So one should be very careful to aspirate on the side arm, especially when we are removing it after some hours. So aspirate on the side arm, good backflow, you can take it out. No good backflow, keep the traction on, hold it, so that if there is a clot in the sheath, it will stay there. And when you come out, let some blood flow through the puncture site, so that again if there is a clot around the sheath outside, it will come out, then apply the pressure. Don't apply the pressure immediately. Let some blood leak and then apply the pressure. And when the pressure is applied, ideally it should be applied in such a way that we have 3 fingers on the artery where it is punctured, on the puncture site, 1 finger above the puncture site, 1 finger on the puncture site, 1 finger below. So it should be 3 fingers, not a Vado ball which is just pressed blindly, but 3 fingers, and then you can keep your second hand on top of that. So 3 fingers. And ideally, in such a way that you can feel the pulse with the right hand. You press with the left hand, feel the pulse with the right hand, dorsalis pedis. If the dorsalis pedis is patent, it means that you are just stopping the bleeding but not completely occluding it. If you occlude the artery, there is a chance of thrombus at the puncture site, especially in children. I have had that happen to me. So I am very careful when I am pressing. I just make sure there is no bleeding, but blood flow is continuing. Especially in children, again I will reiterate, one should be very careful. Sometimes there can be spasm. You have taken the sheath out and you find that there is no bleeding and nothing happening. So that can be spasm. So if that happens, we inject xylocaine around the artery, 1% xylocaine around the artery. There may be a hematoma, and this hematoma may form during the position of the sheath inside. Sometimes the arterial hole, especially if it's a fragile artery, artery which has been punctured many times, around the sheath there may be some leak and hematoma collects. So best is to keep it pressed at that time and stop the bleeding. So you need some assistant or some technician or some nurse or somebody to keep that pressed so that the hematoma doesn't form. And when we come out, if we keep it pressed for about 30 minutes, it should not bleed. So after we've taken the sheath out, after we make sure the bleeding has stopped, always get the patient to raise the leg and always rotate the leg to make sure that there is no hematoma. So the most important and difficult complication is hematoma, which can be local, and luckily retroperitoneal hematoma is very rare. Retroperitoneal hematoma occurs if the puncture is above the inguinal ligament. If your puncture is below the inguinal ligament, the hematoma will be in the thigh. The whole thigh may get discolored right down to the knee, but it will still be below the retroperitoneal hematoma can be disastrous. So there are reports of patient having a retroperitoneal hematoma and the operator himself losing control of his sphincters. So I think that is a gruesome problem that one can have, but therefore always puncture below the inguinal ligament, hematoma. If it has formed, best is to, if it is liquid, squeeze it out or keep it pressed until the bleeding stops. And sometimes if it's a big hematoma, you may inject hyalase. Hyaluronidase comes as a powder, you have to dissolve it in saline and inject small alicos with a 26 or 25 or a 24 number needle in different parts of the clot, and usually it gets absorbed. Of course, you have to keep a careful eye on the peripheral pulse, make sure that the peripheral pulse is there. Similarly, in the evening, at the end of the day, one should always, especially those who are beginners, should always see the puncture site in the evening and peripheral pulse in the evening, whether it is there or not. So the next common complication is a thrombus at the puncture site. And that again is more common in children, because when we press in children, many times we have to close both arteries because we puncture both walls. So we have to occlude the artery, so thrombosis is more common. So if there is a thrombus, you can try with heparin, but usually a thrombectomy is required, and that is surgical. So the vascular surgeon will go in there, do a thrombectomy, and pass a Fogarty down towards the leg to pull out any clot which may have migrated distally. So thrombosis is, again, since we are not reusing, very rare, but especially when you reuse, the chance of thrombosis of the puncture site can happen. False aneurysm we see more when we do a single wall puncture. That is the bane of single wall puncture. And false aneurysm again is because of improper pressure. And as you can see here, most of the times the neck is narrow. The patient will complain of a pain and swelling at the puncture site. Sometimes it can be difficult. Is this an aneurysm or is this just a hematoma? Clinically, it may be difficult to make out. The pulsations usually in an aneurysm can be felt, but sometimes if there is a hematoma covering it, the pulsation may not be pulsatile. Part of the aneurysm may not be palpable. In which case, an ultrasound should be done, and under ultrasound, usually the aneurysm gets picked up. And the treatment also can be done the same way. Pressure with the ultrasound, see where exactly the opening is, and apply pressure with the ultrasound probe and hold it in place for 30 minutes. So once it is held in place for 30 minutes, usually the aneurysm hole closes, and I would say 90% of the time, if the aneurysm is recognized early, once it is an established aneurysm, say you recognize it 2 weeks later, 3 weeks later, then it may not close, because by then the aneurysm opening is too large and it will not close. But if it is recognized early, just with pressure, even if it is a fairly large opening, just with pressure, usually the aneurysm hole shuts down. Rarely, it may not close just with that. Then the injection of thrombin is made. Now, when you make an injection of thrombin, again, it is better to do it with ultrasound guidance, so that you inject only into the dependent part of the aneurysm, so that there is no distal migration. So this thrombin it's a combination of two, which surgeons will know what it is. It is the same thing that we use for hemostasis. So it's two things which is mixed together, and then with a 24, 25 G needle, the aneurysm is punctured and this injected in small quantity. We inject very small quantity, wait and see whether it closes, That's how it is done. If the aneurysm still persists, which is very rare, then you may have to use a covered stent. And we have had to use that in one patient. Absolutely clean puncture, no problem at all. Probably the pressure was not applied properly. This patient came back, and 4 days later, I think, within 4 days, his aneurysm had become big. We could not close it with pressure. Finally, we had to go from the other side and deploy a flow diverter. What am I saying? Flow diverter. We had to deploy a covered stent. But you can deploy a covered stent above the bifurcation. Below the bifurcation, you cannot deploy a covered stent. Above that bifurcation of the femoral artery, to the profundi and the superficial. Fistula is a rare thing, or a rupture, leak in the artery is a rare thing. This is a picture, the next one, this is a picture which was given to me by Dr. Manish. He had done a he had done an intravenous thrombosis, intracranial venous thrombosis. He had done a thrombolysis. He had gone for the arterial side from right side, venous side from the left side. And some hours later, the patient went into shock. And then they realized that there was a big swelling in the flank with discoloration. So that's called the Turner's sign when it is in the flank. They did an ultrasound, found a big hematoma. Then angiogram was done. And on the angiogram, uh, Gigi, if you can show that, yeah, you can see that leak. Yeah, that's a leak. So when there is a leak like this, you have to close it because the hematoma will just. So this patient was given blood transfusion. Patient was revived, and then a microcatheter was taken in there, and glue was injected. So it can be, yeah, you can see he has got the microcatheter in there, and then he injected glue to close that artery. So it's a rare complication. So the lesson is that before you finish, before you come out, now you can see it is clean. So before you come out, always do a check angiogram, make sure that there is no complication. Especially for those who are beginning, always do a check angiogram of the femoral puncture. So to conclude, you have to be very careful whenever you are doing an angiogram. Don't take anything as routine. Always palpate before you begin anything. Try and get a single wall puncture, especially in fat patients and infants. Ultrasound may be a good tool to use. If there is ooze by the side of the sheath, apply pressure so that it stops. Always aspirate on the side arm and removing the sheath. And if there is no backflow, maintain traction on the piston so that there is no clot which will go migrate distally. If there is spasm, inject xylocaine. If there is a big hematoma, inject Hylase. And this is very important. Pressure over the arteriotomy side, not skin puncture. The skin puncture is half a centimeter or 1 centimeter below the arterial puncture. So if you press at the skin puncture side, bleeding will in fact continue. And at the end, of course, pressure dressing is applied. In fact, I was telling yesterday, at KEM for 20 years, I never applied a pressure dressing. It was just an ordinary gauze. Because after you finish, always make sure patient lifts his hand, lifts his leg, rotates in. If he is able to do that without any problem, it will not happen. But I think since many times we don't remove the sheet ourselves, it is removed by the technician or by the nurse. It is safer to apply a pressure dressing. But especially for beginners, it might be a good idea, even if the technician is there, do it yourself. Especially in children, always do it yourself. Because in children, it can be crucial to make sure that there is no hematoma and there is no thrombosis. Both hematoma as well as thrombosis. So pressure dressing, I don't like a sandbag personally, but I find that most people, in any case, use a sandbag at least for the first 1 hour or two. And if the INR is high, then you may need to use it. If you are affluent, cost is not an issue. You can use a closure device. And I do not recommend it. I think it is always, after a diagnostic angiogram, better to make sure that you have stopped the bleeding immediately. But if you wish, you can use a closure device. And the closure device, the cheapest closure device, the angio seal, costs 12,000 rupees. And unfortunately, I don't have a video of the angio seal, but angio seal can be used to close. The other one, which is called per close, is much more expensive. It's about 24,000 rupees, I think. But the per close is used essentially when your sheath is large. Like the peripheral guys, when they are doing abdominal aorta, float aorta, stenting, they have these stents for the abdominal aorta. They use an 11F sheath or a 12F sheath. So there the arteriotomy has to be closed surgically. So either you do it surgically, which means the surgeon has to go in and close it, or you can do it this way, endovascularly. So it's like a stitch. The per close is actually a stitch on the arterial wall. The angio seal is a piece of sponge, a gel foam, which sits in the opening and bulges on either side, inside and out. So it bulges on either side of the opening arteriotomy. But angio seal can be used safely. It is cheaper also, 12,000 rupees. So we tend to use an angio seal whenever we have done, for instance, an aneurysm, we have done a carotid stenting, or we have done an intracranial stenting. At the end, we always use an angio seal after we have finished. And I did not mention at the beginning, but make sure that you are using a sheath of the correct size. Because if you are going to use a device for which you need a 7 French catheter, you cannot use a 4 French sheath. Then, or you start with a 4 French and have to exchange, or you start with a 7 French and do everything through a 7 French. Today you have 4 French catheters for diagnostic angiography, so you can use a 4 French sheath. But if for some reason, suppose you want to switch to a SIM 2, or you want to use one of these other catheters which you don't have a 4 French of, then you are in trouble. So at least I think most of our time we use a 5 French sheath, so you can use either a 4 or a 5 without any problem. So most important, don't treat any procedure as routine. Always prepare for the worst. Thank you.
I think we were planning for a shorter session. It's already 40 minutes.
Oh,
So what I
40
would
minutes?
suggest
My
the
God.
yes, sir. What I would suggest the viewers is that, and I request all the people who are having the link to share it to your friends who are doing fellowship or who are might be interested in doing interventions or to know about interventions. This particular video, and whoever has got any question, you can ask, actually put it in the comment box in the YouTube. In a later session, we'll try to answer all the questions as a separate session. There is one question which I want to share now. Kaumil Kotai, sir, any special situation when we need to check ACT before sheath removal? We'll just answer that question and then finish it.
If it is just a diagnostic angiogram, usually we don't need to check. But if you have done a therapeutic procedure where you have used 3,000, 5,000, 6,000, then it is safer to use. And we should not remove the sheath if it is more than 200. So usually if the ACT is up to 200, you can remove it safely. And the half-life of heparin is 1 hour. So if you have used 3,000 units, after 1 hour it will have come down to half.
There is one more question. Lijo James is asking how to identify dissection, sir.
So clinically, when you are pushing a wire through, the patient will complain of pain. The patient will jump. So either it will be local pain or it will be flank pain or back pain. So clinically, immediately the patient complains of pain. The other is you have to inject contrast and see. So when you inject contrast, part of the contrast will be in the lumen, part of it will be in the wall, part of it will be outside the wall, depending on which level the dissection has occurred at. If it is intima, media, adventitia, contrast will go all the way out into the periarterial space. Otherwise, it will track along the flap. And when you inject contrast, you will also see the flap. But most important is pain. Pain is very, very significant. If the patient, when you are passing a wire, patient complains of pain, it means you are sublingual. So stop. And as I said, even if there is a dissection, unless you have caused a big tear in the artery, nothing happens. Just press, just wait for a few minutes. If you are very worried, do an angiogram from the other side. But I can assure you, 99 times out of 100, dissection in the femoral artery is not a great consequence.
Dr. Muthukumaran recently completed the fellowship with us. He has just finished and left. He is asking this question: 18 gauge versus 21 gauge micropuncture needle for the femoral puncture, pros and cons.
18 gauge, the advantage is you don't need to do 2 steps. 21 gauge, you have to use a delicate wire. You have to use a 21 wire. 18 wire won't go, the 35 wire won't go through. So if the patient is an adult, the skin is thick, subcutaneous tissues are thick, the thin wire doesn't support the regular dilator and regulation, then you have to use a micropuncture set. So in a child, we always use a 21 or even a 22. So there we use a 0-2-1 wire. But in adults, 18 is good enough. Even a child above 9, we have always used an 18. Child below 8, probably we would use a 20G.
And last but not the least, as I said in the beginning, this is not a webinar. This is a continued process. It's a continuum. That means we are just recording this content for the YouTube so that anybody can view this video anytime. You can share it with your friends. Go through the video when you have time. Most of the time, many people who are not listening to this video at this time, you have the opportunity to listen to the video anytime you want. And what you should do is in the comment box under the YouTube, just write your questions, with your comments, your suggestions, whatever it is. And in a later session, we'll try to answer all those questions in another session when there are enough comments or suggestions or things to be clarified as a separate session. So thank you. We have run out of time. It's almost 47 minutes, which was far beyond our expectations. And when sir's talking, then no way you can, sir, because of the passion to teaching, you keep continuing to talk. Anyway, we'll have the next session maybe in the next couple of days. Thank you for your patient listening and support. Please do share this video with your friends, and also subscribe to this YouTube channel, which is Brain Matters. And there is a bell icon next to the the subscribe button. If you press the bell icon, all the new videos will be notified to you immediately. So thank you, and see you next time.
Thank you.